Hello my dear friends, it's been a while since my last update on this channel, but today I'm excited to share some good news. Last week we published a new paper in the Journal of Clinical Medicine. The title is A Comparative Study of the No-Punch Technique in Reducing Surgical Complications in UBE Spine Surgery. This is a Q1 SCI journal with an impact factor of 3.3. And we are very proud to contribute to the advancing field of minimally invasive spine surgery. Let's start with a quick refresher on UBE surgery, or unilateral biportal endoscopic spine surgery. This method involves two small surgical incisions, one for the endoscope and saline inflow, and the other for instrument access and outflow. Thanks to the ongoing irrigation and a magnified view, the endoscopic field remains bright, clear, and nearly bloodless, enabling us to carry out very delicate and precise procedures. UBE has become widely used for degenerative spine disorders. But despite its many advantages, surgical complications still occur, particularly dural tears, which remains the most common. Literature reviews suggest an incidence rate of around 4.5%, and we all know that how complications can undermine even the best surgical outcomes. Now here's where our study makes a breakthrough. The Carrison punch, invented in the 18th century by a British surgeon, Robert Carrison, has long been a considered cornerstone of spine decompression. However, based on our analysis of over 900 cases, we found that the Carrison punch is also the most common cause of nerve injury, accounting for over 90% of observed nerve injury in traditional decompression cases. Many articles and studies suggest that nerve injury or dural tears during endoscopic surgery are usually minor and can be managed conservatively without significant long-term effects. However, in our study, we observed some complications, including permanent issues like sensory deficits, motor weakness, and delayed recovery from general anesthesia. This finding conflict with the traditional view presented in other studies. Therefore, we believe that neuroinjury can result in serious long-term consequences. This is the primary reason we recommend the no-punch decompression technique to help prevent nerve injury. In our technique, we completely avoid using the Carrison punch. Instead, we use a high-speed burr for bony decompression, curve the chisel and osteotome to release the ligamentum flavum from its peripheral attachments, and finally, a pituitary clamp to in block remove the ligamentum from peripheral to center. This approach not only reduces trauma to the central dural structures, but also helps preserve the facet joint, an important contributor to spine stability. To prevent injury, it is essential to understand the injury mechanism first. In cases of severe stenosis, dense epidural adhesions and neovascular inflammation are often present beneath the ligamentum flavum. During open surgery, this can be difficult to detect because blood can obscure the view. However, endoscopy allows for a clear visualization of key features: adhesion between the dura and the ligamentum flavum, the so-called central dural fold created by water pressure, and the vascular tissue that increase the risk of a tear or nerve root injury if instruments are inserted blindly. By avoiding blind insertion of the Carrison punch into the vulnerable areas, we significantly lower the risk of unintended damage. These illustrations demonstrate why blindly insertion of surgical instrument through the central slit and the lateral recess can lead to dural tear or nerve injury, particularly with Carrison punches. In this video clip, we demonstrate how to use a curved chisel to undercut the medial border of the ipsilateral facet joint, releasing the ligamentum flavum from its peripheral attachment. Then we use an angled curette to separate the ligamentum flavum and a micropituitary clamp to remove it in one piece. Then we go to the contralateral side, use a straight chisel to undercut the medial border of the contralateral facet joint, releasing the ligamentum flavum from its peripheral attachment. Then we use an angled curette to separate the ligamentum flavum and the micropituitary clamp to remove it also in one piece. The remaining offending structures also removed using the Carrison punch, curette, and the pituitary clamp. These photos demonstrate the sequential steps of ULBD using our no-punch decompression technique in the UBE surgery. In summary, our no-punch decompression method involves using a high-speed burr to access the lateral recess, the straight and curved chisels. In summary, our no-punch decompression method involves using a high-speed burr to access the lateral recess. Straight and curved chisel are employed to undercut the medial border of the facet joint and to release the ligamentum flavum. Finally, the ligamentum flavum is removed in one piece with a pituitary clamp, ensuring the preservation of both the dura and the facet joint. This technique also saves time, particularly when decompression of multiple segments is needed. The stenosis was effectively relieved while preserving the facet joint and the paraspinal muscles. Between 2018 and 2023, we carried out a comparative study with 914 patients. 600 patients received traditional decompression using Carrison punch, while 254 were treated with the no-punch technique. The key findings include the neural injury rate fell from 5.3% to 0% in the no-punch group. The only injury encountered was a thermal injury caused by ultrasonic equipment, not mechanical trauma. This demonstrates a significant reduction in risk. Additionally, we observed that this method was highly effective even in revision cases, which generally have a higher complication risk. In conclusion, to prevent nerve injury and dura tear in UBE surgery, we should understand the injury mechanism and avoid the outdated practice like blindly inserting the Carrison punches through the central slit. Adopt safer alternatives such as the no-punch decompression technique. By updating our approach, we can enhance the safety, effectiveness, and the stability of spine surgery. If you are interested in learning more, you can find our full article in the Journal of Clinical Medicine. The link is in the description, or just scan the QR code on screen. Thank you so much for watching. Please like, share, and subscribe for more insights into minimally invasive spine surgery. See you next time.